Good afternoon, and welcome to Equip's first ever virtual open house. I'm Jessica Hickman, Equip's Senior Manager of Community Partnerships, and I'm excited to be joined today by so many providers and community members. Thank you for your interest in Equip. Here's our agenda for today. In just a few moments, you'll meet our co-founders, learn about Equip's revolutionary treatment model, and even tour Equip. You'll hear about the power of mentorship and see how Equip's patients are truly getting better. We'll end things with how to refer, followed by a live Q&A with members of Equip's clinical leadership team. If you have questions for us, you're welcome to drop them in the Q&A box at the bottom of your screen, and we'll answer as many as we can. In 2019, Equip set out on a bold mission of making gold standard eating disorder care accessible to everyone who needs it. And we are well on our way as we continue to open our virtual doors across the country. Now, I'm so excited to introduce you to Equip's fearless leaders who have made this all possible. Joining us today are co-founders Christina Safran, CEO, and Dr. Erin Parks, Chief Clinical Officer. Both Christina and Erin have dedicated their careers to the eating disorders field. Christina is the founder and former CEO of Project Heal, a nonprofit dedicated to raising money for individuals who do not have financial access to treatment. Erin is a clinical psychologist and researcher who became inspired to solve for geographic barriers to evidence-based care during her time as a director at UC San Diego Eating Disorder Center, where she witnessed families flying from all over the world to get this evidence-based care. Christina and Erin have combined their lived experience and clinical expertise to form what we now know as Equip. Please welcome Christina and Erin.
Thanks, Jess, for real now. And you can see how excited I am just wanting to jump in with everyone here. But we are so excited that you're here to learn a little bit more about Equip. Thank you so much for coming. Just briefly, Christina Safran, co-founder and CEO, and I have been working in eating disorders for what feels like my whole life. I was diagnosed with anorexia at 10 years old, struggled throughout my adolescence, was fortunate that after having access to family-based treatment, I reached recovery. And upon learning that 80% of the 30 million Americans with eating disorders don't get treatment, I've really been on a mission to ensure that everyone has access to treatment that works. As Jessica mentioned, I founded Project Heal at 15, and it's still an active part of that organization. They're doing absolutely incredible work, but was raising money to fund treatment one by one. And while we were reaching hundreds of people, I was acutely aware that we weren't reaching the millions of people who really needed help. And so Erin and I decided that, academia and nonprofit, maybe we're moving a little bit too slow to help all the folks that we needed to help and reach, and have been so thrilled to be building Equip to ensure that all families have access to evidence-based treatment. Really thrilled to introduce my co-founder, Erin Parks, as well.
Hello, everyone, and thank you so much for being here today. I'm Erin Parks. I'm a clinical psychologist, and I was so fortunate to train at UC San Diego and get to work at UC San Diego's Eating Disorder Center. And while I was there, and I think many of you can relate to this, we watched people travel from all over the country to get treatment there. And then we knew that that meant that there were lots of people who weren't able to travel to eating disorder centers to get care. And so Christina and I would see each other every 6 months and talk about the financial access issue that she was experiencing and the physical access issue that I was seeing. And so we joined forces together and we founded Equip. And we're glad you're here today so we can tell you a little bit about what Equip is, the patients we've been serving, and let you know a little bit about what we've been up to in the past years. So let's meet Equip. I can't talk about Equip without talking about our amazing clinical leadership team. We have been so grateful to all of the people here and so many more who've joined us after having built their careers in academia at Stanford, at UC San Diego, at Columbia, at Duke. And all of them, while they loved the places that they'd worked, were really excited to come and be able to move a little bit faster and do something innovative and figure out how can we bring virtual care to everyone who has an eating disorder. And in addition to our wonderful clinical leadership team, we also have some advisors that have been helping us out. So first is our clinical advisors. As someone who is a provider myself, I've watched my friends in private practice struggle with either loneliness or having difficulty collaborating. Like maybe they're a therapist, but it's hard for them to find a dietitian and a psychiatrist that they can have a shared medical record and collaborate with. But also I've watched my friends in hospital settings struggle with RVU models that maybe weren't designed for mental health. So we wanted to build a QUIP that wasn't just a place for patients, but also for their families, but also for providers. Mental health providers are needed now more than ever. We're very concerned about burnout and making sure that people can really operate top of license and do what they've been trained to do. So we're super grateful for all of our clinical advisors who are making sure that eQuip is delivering the best possible treatment and is also the best possible place to work. And then most importantly, our community advisors. So our community advisors, many of them on this slide and some even more, represent the lived experience. People who had eating disorders themselves or whose children had eating disorders or whose siblings, and they really understand the unique challenges of not only seeking treatment, but getting through treatment. And they have made sure that we are really making that eQuip is a safe place for everyone to get care. So a huge thank you to our clinical and community advisors. Could not have built this without them. So what is our treatment philosophy? So this is kind of the foundation of what makes up eQuip. So first is that eating disorders are brain disorders. No one chooses to have an eating disorder. And also recovery is really difficult because your brain is telling you one thing while you're trying to do something else. We also believe that food is healing. While it's super important to heal the emotional aspects, it also is important to get the nutrition that you need. We strongly believe in health at every size. We know that fat phobia is rampant in our culture and in our medical system, and also that gets in the way of people getting care. We know that eating disorders affect people of all shapes and sizes, and recovery happens at all shapes and sizes. We also strongly believe in data-driven treatment. This is maybe the soapbox I spend the most time on, that it's not enough for treatment to feel good. Treatment has to work and it has to be lasting. We believe that full recovery is possible. And lastly, we believe that care should be accessible, that everybody deserves access to excellent treatment. And this means financially accessible, physically accessible, and also access to the technology. So what is the eQuip treatment? Christina, walk us through. Oh, I'm going to take this part too. Sorry about that. Okay, in order to understand the eQuip treatment, we have to first talk about FBT. So for half the people on this call, they might be like, wait, I have no idea what FBT is. And then the other half might have really strong reactions, really liking FBT or really being skeptical of FBT. So let's kind of just level set and remind everybody about what FBT is. So FBT was developed in the 70s and 80s at the Maudsley Hospital in London, which is why it was called the Maudsley method for a while. And then in 2001, which shockingly was 20 years ago. I don't know if many of you are like me, it feels like that was maybe 5 years ago, but 2001 was 20 years ago, and Drs. Locke and LaGrange published the manual and really were spearheaded sharing the word and making sure everyone knew about FBT. And then in 2019, we built eQuip, and FBT has been found in over 6 peer-reviewed randomized controlled trials to be found more efficacious than any other treatment. And hundreds of peer-reviewed publications have been written about how much FBT has helped people to get better. Unfortunately, there's a shortage of FBT trained providers. And a lot of the FBT trained providers that I know either have wait lists or they aren't able to take insurance. And really a lot of FBT has been stuck in academic settings. A reminder of like what FBT is. There's kind of 5 core tenets, and one is an agnostic view of the illness. So we don't waste time on where did this eating disorder come from. We think, okay, what's going on in the present moment and how can we make it better? We focus on symptoms, prioritizing nutrition and a prevention of eating disorder behaviors. We put the healthy people in charge. We say family in charge, and it's truly whatever family is for you. I like to compare it to if you thought your 15-year-old was struggling with substance use, you should make it difficult for your child to use substances. So while they're at soccer practice, you should search their room, and if there's alcohol under the bed or in the closet, throw it away. Same thing is true if you think your 15-year-old is vomiting after dinner. Then after dinner, it becomes a family rule that you can have unlimited screen time, but you need to be where I can see you. And so that's what family in charge is about, is structuring the home for pro-health behaviors. FBT takes a non-authoritarian stance. Something that I particularly love is this idea that we are not experts on everything. We just are experts on eating disorders, and we're going to help make you an expert in an eating disorder. You are the one who's an expert in your family. And then lastly, externalizing the illness so that the family and the patient can unite against the illness instead of it being sometimes stereotypically parent versus teenager. So the tenets of FBT. And FBT has really positive outcomes. About 86% of people will get better with FBT or have their symptoms ameliorate. That being said, maybe only about 50% of people will have full and lasting remission with FBT. And one of the joys of Christina and I coming from our previous lives is that we've met thousands of patients and their parents who've helped us understand either why FBT worked for them or why it didn't, what else they needed. And so we took all of these learnings and thought, if FBT is the foundation here at Equip, what are the things that we need to add to it so that it works for more people? And that's what we did. We built upon FBT. Go ahead to the next slide, and Christina will
So how are we getting folks to reach 100% recovery? So a couple of core differences between Equip and FBT. The first is that traditional FBT comes once a week by a therapist. We give everybody, we heard loud and clear from families that that was not enough support. And so we build families a dedicated 5-person care team. Everybody gets a therapist, a dietitian, an MD, a peer mentor, and a family mentor. Importantly, all of these folks are Equip employees. They train together, they're supervised together, they're united, they're on the same page. This is what we hear from families again and again. That is really the difference from traditional treatment. And then finally, folks have access to unlimited sessions and unlimited messaging with their care team. We very much believe in a philosophy of not wanting to overdose folks on treatment that they don't need, but giving them just the right support in the moment when they need it, and then say, go out, live life, build a life worth living, build up triggers, and bring them back to your treatment team. We also adapt treatment to be fully virtual. One of my favorite anecdotes to share, many of you know that this was our plan pre-pandemic because access was our North Star. And we have really seen that virtual is the best approach for eating disorders. And I think that's for 2 main reasons. One, I talk a lot about this idea that you can't build a life worth living if you're not living life. And unfortunately, a lot of our existing treatment modalities take people out of their lives and don't give them that opportunity to be in theater, be in soccer, build up reasons to want to drown out the eating disorder. And then the second is, FBT is hard, right? It's a lot of hard work for the parents, for the family. And we know that treatment works best when you can include your entire village in treatment. When I was going through FBT, both my parents worked. It was rare that they could both come to sessions. Now we have families bringing truly their village, 4 or 5 grown adults, sister, aunt, and we know that treatment works better in that way. We add mentorship to help patients stay in recovery. I could go on about this all day, but I won't because Maris and JD will tell you about it. But suffice it to say that we really center the lived experience at Equip, and it's really wonderful for patients and families to have that constant example of, I know this is hard and keep going. This is hopeful. This is possible. It's worth it. And I'm going to show you that there is a life worth living outside of your eating disorder. So really excited for you to hear from Maris and JD. And then finally, we meet underserved communities where there are. As we go along with this presentation, you'll see that there are a lot of changes we want to see in the eating disorder field. One big one is that our field has been a pretty homogenous field due to lack of training. And we know that eating disorders affect people equally across race, class, ethnicity. We know that 30% of sufferers are men, only 6% of sufferers are underweight. As the food insecurity in a community rises, eating disorders directly rise. And so what we've been able to do is really go out into the communities that we know are affected and bring them onto the Equip team so that now every family can be matched with at least one member of their treatment team who identifies with some aspect of their lived experience above the eating disorder. We have BIPOC teams, we have LGBTQ teams, we have transgender teams, we have Spanish speaking teams. We actually have a family mentor who is homeless living in her car when she refed her daughter from an eating disorder. And we know that treatment works better when you can relate to folks. And then finally, access is really at our North Star. And we know that folks can't solve access gaps if they don't have technology. And so we're able to send them devices, hotspots, and also our dietary team is helping families to connect with resources in the community if they're experiencing food insecurity.
We want to give you a little tour of Equip and see what it's like. Since it's all virtual, we couldn't bring you to an open house where we walk you around. So this is our version of walking you around. I'm going to show a little bit of video of what it looks like to be a family using Equip and what the technology looks like. think there was some beautiful instrumental music that was going to be behind that. So sorry that you missed out on that. But I hope that gave you a little glimpse of what it looks like, whether you're logging on from a website or for an app to access Equip. Move on to the next slide. And I want to talk a little bit about the power of mentorship. And actually, Melinda just asked a great question in the chat that our first guest, JD Olette, who is our director of mentorship, can address as we talk about who our mentors are and how they've been trained.
Hi, I'm so excited to be here today talking about our mentor team. Maybe we can go to the next slide. Great. You can see we have a really diverse group of people, which is amazing because eating disorders happen in all families, as Erin and Christina have been talking about. So what the family mentorship and what mentorship does in general is we normalize what's happening and we solve the problem from the kitchen table, which is where the problem gets solved. So from that perspective. So normalizing that effective treatment is counterintuitive and really hard is super important. And I know that because it was really important when we went through treatment at UC San Diego. We also offer hope. So if my family can be living with a fully recovered daughter and living a fully recovered life, so can yours. We're able to support families, again, from that lived experience perspective, and we're able to suggest things that might work, to develop skills with families, to help drive authentic solutions in collaboration with families so that they work for them and within their daily lives. And I'm really excited that we also offer multifamily groups virtually, where families get to connect with other people at the same stage as they are, maybe further along in their journey, and again, continue that normalization of this very, very hard work that is possible to do. So when you have a mentor who is showing you that recovery is possible, it also begins to feel inevitable. And that's what we're here to provide. And we do it really well. So I'm very excited to be here today.
Yeah, JD was the first person that we asked to join our clinical team because while I spent a ton of time training as a clinician, it wasn't until I started practicing that I realized what was missing. And that was my knowledge of what it's actually like for parents who are with their child day in and day out. And now as a parent myself, I understand that when your child isn't well, it affects every cell of your body. And we task parents to do some really hard things, and having family mentors be with us and help our families along has truly been part of the secret sauce. The other half of it is our peer mentorship. So we're excited for you to meet Maris. Maris is our manager of peer mentorship, and would love for you to talk, Maris, a little bit about the training that we provide in your peer mentorship team.
Absolutely. I'm so excited to be here because I love working with our peer mentor team because they're just the coolest group of people. You can't even tell just from seeing their pictures. But our peer mentor team is made up of folks who all identify as being in a solid space of recovery, which in and of itself holds a multitude of stories. You know that no two recovery journeys are exactly alike. And there's some common themes that can be really, really powerful in supporting our patients and families. So our peer mentors, first of all, serve as living, breathing proof that full recovery is worth it and that it's possible. And it's worth all the hard work that it takes because we know that it's really, really hard work. But luckily, our peer mentors are able to share with patients a variety of tools and skills and resources and anecdotes that can all really help our patients through those more challenging moments. Something I really love about our peer mentor team is that we get to work with patients on discovering what they want their recovered life to look like. We call this building a life worth living. So discovering the things that motivate you towards recovery and then also keep you in recovery in the long term. Another thing I really love about this group of people, including our family mentors, is that these are people who have been doing this work. So not only did this happen in their own lives, but these are the people who are activists and allies and have been taking calls from a friend of a friend about eating disorders, sometimes for years. So these are folks who now get to really formalize that work, not only get to be compensated, but really receive ongoing training and supervision that's super hands-on and covers everything from eating disorders 101 to the intersectionality of eating disorders and how they can support patients and families from a variety of backgrounds.
Thank you so much, Maris. So our family mentor and our peer mentor are just part of the treatment team. So every single family gets a family mentor, a peer mentor, a therapist, a child and adolescent psychiatrist, or a pediatrician, and a dietitian. And all of these people are employees of Equip. They train together, they work together, they meet weekly, or oftentimes multiple times per week. And we also do record sessions and are able to grade it for fidelity to the model. And I want to tell you a little bit about what's happened when we've given families these 5 or 6 person treatment teams. I want to tell you a little bit about our outcomes. How do we measure outcomes? First of all, we are always measuring, using different validated measures of symptoms. So we use a PHQ-9 for depression, the GAD-7 for anxiety. We use several different measures to look at eating disorder symptoms, but we also measure how the family is doing, how are the parents doing, how is their caregiver burden. We know that treatment fatigue is very real, but also caregiver self-efficacy. That's been shown to be an excellent predictor of whether someone recovers and whether we're able to prevent future relapse. People also are, we are also constantly measuring people's weight, their vitals, and we do this all through the app, through the phone. And so on a regular basis, we are able to get these symptom inventories, get their weight and vitals, and make sure that we're getting them physically healthy and emotionally healthy. We've been serving patients for a full year now. I think it was a year last month. And we have started to publish our outcomes. And here's kind of a little snippet of how things are going. So first, from the patient side, 96% of our patients are getting better. And I hope you're all thinking, well, what does better mean? And I love that people should be critical and really make sure that people are having meaningful change in their life. So one way that people are getting better is that they're healthier. 96% of our patients on weight restoration, they're gaining weight, and we set a high goal of gaining an average of 1 pound per week, and they're achieving that. 81% of our patients are seeing an improvement in their eating disorder symptoms as measured by the EDQS and a few other inventories. And 80% of our patients that have depression or anxiety report improvements in their mood. But we're also seeing that it's not just the patients who are getting better, the parents are feeling better as well. And as a parent, I think that's what matters most. I want to know, am I going to sleep through the night? Am I going to be worrying about my child every day? And what we're seeing is that by week 8, 80% of parents report an increased confidence in their ability to fight their child's eating disorders. We're seeing 62% of parents report a decrease in caregiver burden, and also that 90% of parents love Equip treatment. The treatment that we are giving is pretty hard. We ask families to be very involved, and we know that especially in the beginning, it's hard work. And so it says a lot that we're having actually over 96% of our patients retained, and they stay with us month over month. I want to dig in a little bit on the next slide. So many of us here at Equip are researchers at heart. So sometimes we show slides like this and marketing teams are like, oh, this is way too detailed. But I want to let you know that we really, really care about outcomes, and we're able to measure them in real time. Every day I can refresh my outcome dashboard and see how things are doing or things are going. So right now at Equip, 80% of our patients are on weight restoration, and they come to Equip having an average of 20 pounds of weight to gain. But we've seen some people who have 45 pounds of weight to gain. Our goal is for everyone to have a minimum of 1 pound per week of weight gain if they're on weight restoration. And you can see by this graph here that by the time we hit week 4, our patients are consistently gaining 1 pound per week. Now, while 80% of our patients are on weight restoration, we aren't only treating people with anorexia. About 15% of our patients have ARFID. We also have some patients with bulimia, with OSFED and binge eating disorder, and also patients with a lot of different comorbidities. In order to measure how those patients are doing, we're taking a look at their PHQ-9s, their EDQSs, and looking at how their symptoms are decreasing over time. I want to tell you a little bit more about who our patients are. So on the right, you can see that we have yet to really treat anyone who only has an eating disorder. And all of you who've been treating eating disorders for a long time probably see the exact same thing. So a lot of our patients struggle with depression and anxiety. Right now we have a younger population. Our average age is 15. So we're seeing less PTSD than we will as we treat older populations. We also treat comorbid OCD, ADHD. We've had many patients on the autism spectrum, and we've had several patients that were also working on substance use disorder at the same time as working on their eating disorder. We were able to bring them to sobriety while also working on their recovery. Also, our patients have had various different eating disorder treatments before coming to us. So about a quarter have never had eating disorder treatment before. Equip is the very first thing that they tried. But 70% had tried outpatient before, and over a third of our patients have been in inpatient medical stays before. And in fact, about a third of our patients come to us directly from an inpatient medical stay. Nearly half of our patients have moderate to severe suicidal ideation, and 6% have made a suicide attempt in the past. So while we are here for people who it's their first treatment episode, we also are equipped to handle fragile and complex cases. And one of the reasons for that is that we do have this 5 or 6 person treatment team with the unlimited sessions and unlimited between session messaging, so we can meet the patient where they are at as they're living their lives. We have been incredibly grateful to our advisors, many of you who are on this call, who have believed in Equip from the beginning, who've referred your patients to us, who have been cheerleaders of ours. We know that we were an unknown for the first year. We were new, and so many of you believed in us, and we're I guess the biggest amount of gratitude goes to the families that joined Equip, to the first several hundred patients that we treated that tried something new, that tried a virtual eating disorder program. And we're really humbled and grateful that they chose Equip to help their family, and feel really proud that we've gotten so many people and so many families back to the joy and happiness that they all deserve. We want to make it easy for you all to refer to us, but also to get consultation with us. So if you are a pediatrician or a dietitian or a psychiatrist or a therapist and you're wondering, is this right for my patient? Give us a call and you can talk to our dietitians or pediatricians or therapists and bounce ideas off them and figure out if it's a fit for you. If you go to the next slide, you can see that right now we are serving patients in Washington, Oregon, California, Colorado, Texas, Illinois, Georgia, Florida, New Jersey, and New York. We're able to serve people with all different eating disorder diagnoses and comorbidities. And we are fully covered by several different insurance plans, with many more coming soon. So Aetna, Magellan for Blue Shield of California, Cigna, Horizon, United Healthcare and Optum, Pacific Source, and some Kaiser plans. And we are really proud of the fact that all of the care that we provide is covered. So I know some of us, I've met so many people in the community that are like, oh, I have a dietitian who's covered, but I can't find a therapist who's in network, or I have a pediatrician who's in network, but I can't find a psychiatrist. We give everyone this 5 or 6 person treatment team, and it's fully covered by these health plans. And just a little secret, Medicaid is coming out soon. We're really excited to truly serve everyone. If you're interested in joining Equip, or if you'd like to refer a patient or learn more about us, you can send us an email, intake@equip.health. You don't need to go through any referral channels, doesn't need to come through your pediatrician. You can just contact us directly. Or if you are a pediatrician or another provider and want to consult with a member of our team to see if your family would be a right fit or your patient would be a right fit, you can email us at intake@equip.health. We also have a form on the website at equip.health/providers where you can refer people. We have a phone number and a fax number if you'd like to just call us or send information over, or you can give the family our email address or our phone number and they can reach out to us directly. We have a really robust admissions process. So during the admissions process, we talk to any referring providers or other providers that they're currently seeing that we can have an ROI for, and make sure that they are a fit for this virtual care. And we'll work really closely with you to make sure that your patient gets the best care that they can. Next slide. And actually questions are coming up now. So what I would love to do is invite some of my colleagues on to answer some of the excellent questions that are coming through. So I'd like to invite Megan Holt-Hellner, our nutrition director, Dr. Jennifer Doreen, our psychiatric medical director, Maris Degener, our manager of peer mentorship, and JD Olette, our mentorship director, to all come and join us. And maybe,
Thanks.
Perfect, go ahead, yeah.
Thanks, everyone. Thank you, Erin and Christina, JD and Maris, and Megan and Jen. We're so glad you could join us. We have a lot of questions coming in. You're welcome to keep asking them, and we will answer as many as we can in the time that we have left. So we'll just start going through it. And Oh, this first question is perfect for you, Megan. You joined right on time. Can you explain the RD's role in FBT and how that differs from other settings?
You bet. Yes. And thank you very much, everyone, for coming today. We're really excited to be talking to you about all of this. So in FBT, what is really unique about the RD's role, I'd say, is that we're working directly with the caregivers, which has proven to be very fun and also very effective. We're able to be really transparent in our messaging and our guidance because, for example, we might not talk specific numbers and goal weights with the patient, but we can do that with the parents because they're really on point for implementing the treatment plan at home and kind of taking charge of that renourishment or refeeding process. So we're giving guidance to the parent in a way that's not overly prescriptive. We're kind of coming beside them as a coach, and then they're working with their child to carry them through the refeeding at home.
Thanks, Megan. We have a lot of questions about our mentorship aspect of our program. JD, can you share how patients are matched with their mentors?
Yeah, absolutely. So we look at a variety of, sort of match points and that sort of thing, including time zone to make sure that we're being able to meet people at a time and place that's effective for them and works in their life. And we're looking to match people sort of depending on what they identify as their primary needs. Potentially for someone who's had ARFID, they might want a peer mentor who's dealt with ARFID and a family mentor who's also dealt with ARFID. Sometimes a demographic match is really, really important. So we train all of our mentors in meeting the needs of all of our families, and then we take a look at what information the family puts on the intake form. We have mentors who've done this with sort of over 18s, was it's a subset of issues. So they're probably going to benefit from having a family mentor who also did that over 18. So we look at a variety of places to match, and then we work to make sure that we have the closest match possible.
Thanks, JD. This is a question for Erin. How do you determine if a patient is a good fit for virtual treatment?
That's a great question. And I bet some people are really sick of Zoom, right? We've been doing Zoom for so long now with school, and so many of us went virtual for our meetings. But my answer is that most people are a good fit for virtual. And the reason is it allows them to live their life. So we don't want children, we don't want 15-year-olds or 8-year-olds sitting in groups with other 8-year-olds for an eating disorder. We want them sitting in groups with other 8-year-olds for soccer practice and groups with other 15-year-olds for their play rehearsal. And so virtual, while there's certainly, I think a lot of us are sick of Zoom, the benefit of it is that the appointments can be after school. I have 2 kids. I'm never pulling them out of school again. I'm so glad that they're finally back there. You're not going to pull your kid out for a virtual appointment, but you also shouldn't pull your kid out for an in-person appointment. So this allows your child to be at school all day. After school, maybe they go to soccer practice, or maybe they have chess club, and then they can come and have a session at 5 o'clock or 6 o'clock. We also have sessions on Saturdays as well. I think the people who would not be a fit for virtual, and there have been a few, are people whose family is not able to structure the home for safety. So about half of our patients struggle with moderate to severe suicidal ideation. It's something we're very, very familiar with. And we help the family, the adults in the family, the healthy people in the family, to structure the home for safety. We have had a few people, like 3 or 4, where the parents or the adults in the household were just not in a position to help make the home safe. So those would be the kids that would not be the best fit for a virtual environment, and when we would be suggesting a higher level of care when they can have their behaviors more closely supervised, because the adults in the home environment aren't able to do that at this time.
Thanks, Erin. And Jen, I'd love for you to take this one. How do you make sure that patients remain medically stable while working with EQIP?
That's a great question. So all patients are screened medically before they're admitted. We make sure that they don't meet criteria for medical inpatient stabilization. And then families are actually sent a blood pressure cuff in the mail, and they meet one-on-one with our medical assistant. And
caregivers are taught how to do orthostatic vital signs. They're also taught how to do blind weights at home, things to be on the lookout for. And then they submit that information to the team at the intervals that are requested by the medical provider and the dietitian. We also have the ability to work collaboratively with primary care providers and adolescent medicine specialists. We realize that some folks are really comfortable and want to continue to be very involved, while others are kind of like, I'm good. I will happily see them when they have strep throat, but you guys can take this and run with it. So we're watching really closely. And if we feel like someone is no longer safe to be in outpatient treatment with us, we make a referral to a local inpatient medical stabilization unit.
Thanks, Jen. A lot of questions about the peer mentors, a lot of excitement. I love to see it. Maris, can you explain how patients interact with their mentors? Is mentoring done on a one-on-one basis? Is it in group sessions?
Yeah, such a good question. So our peer mentors are our patients' person. They get to meet one-on-one with them for their entire time in treatment, and how those sessions are structured really depends on the patient's needs. So unsurprisingly, patients arrive to treatment in very different ways. Some show up day one and they're like, I love my peer mentor. Tell me all the tricks, tell me all your stories. And then some patients need to warm up a little bit. So our peer mentors are really skilled at different art activities, how to build trust with patients, icebreakers. And then over time, it can really become tailored to what that patient's working on week to week. So they can share challenge foods together. They can work on certain skills that they're working on. And then we do also have skills group that peer mentors do sometimes attend to support patients in as well.
Thanks, Maris. Another one for you. Can a therapist who has recovered from an eating disorder also be a peer mentor?
It's a good question. When we opened our doors to look for applicants for peer mentors, we got applications from people of all walks of life. So I think it's really powerful to be able to role model that recovery shows up in a variety of different ways. You can recover into being an astronaut, or you can recover into being an eating disorder professional. So I'd say we'd be open to exploring a lot of different applicants.
I love that. Thank you. This one is for Megan, our RD. What is Equip's food philosophy, and how are feeding guidelines communicated to the caregivers involved?
Sure thing. So like you might see across different eating disorder settings, we do embrace the all foods fit philosophy, or sometimes that's referred to as no good or bad foods. And we're really working with the caregivers also to kind of embrace a legalization of all foods, and then to kind of pass that on to the child that's struggling. In terms of how the feeding guidelines are communicated, given that we're able to work with parents directly and they're implementing this at home, we can be explicit with calorie ranges, or just really giving specifics to make sure that the kiddos' needs are met, and that we're able to, for example, weight restore at as quickly as we possibly can, that within the bounds of safety. So we're also giving the nutrition education through the parents, or to the parents, in terms of helping the kiddo get the density of foods that they need without the volume being uncomfortably large, or just kind of strategies for alleviating some of the persistent fullness that might come with refeeding. And oh gosh, what else can I say? As we get a little bit farther along in treatment, we're able to work kind of one-on-one more so with the child in a lot of cases, and then we'll start kind of giving them education, and the feeding guidelines are communicated differently. We're not working from a calorie-based model when we're working with the patient directly, using more of a visual approach.
Thanks, Megan. This also might fall into your wheelhouse. Do we support, help with patients who have GI complications and manage medication in that way, or do we collaborate with outside providers?
Well, I'll have to punt the medication management piece to Jen for sure. But in terms of GI complications, all of our dietitians are really seasoned in GI work as well. It just kind of comes with the territory, and it especially comes with the territory of refeeding. So we do certainly honor food allergies or any kind of issues that may come up that warrant us. And this is part of the benefit of the parents managing the refeeding at home, is that they're able to work around the food allergies in a way that works best for them and their child. Certainly if it's something like a food intolerance that's more so tied in with the development of the eating disorder, that might be something that we would kind of challenge or try to learn more about. But from the dietitian's perspective, they are all really strong in helping the folks with the GI issues from through the lens of a dietitian. But Jen, I'll pass the med management question to you.
Yeah, of course. All of our medical providers are really skilled and experienced with managing the medical complications and the very typical discomforts associated with the renourishment process. That being said, we work really closely with referring providers, with primary care providers, and also with GI specialists if we feel that that's indicated.
Thanks, Jen. We have another question that's for you. Do we work collaboratively with referring medical providers like pediatricians and PCPs, and how do we do that?
Yeah, absolutely. We're always available if referring providers have questions about whether a patient and family would be a good fit for our program. If people have questions about the need for medical stabilization, we're happy to talk about those things. And then, like I said earlier, some of our patients want to, or some of our referring providers feel really comfortable taking care of eating disorders and want to remain involved. And in that situation, we are able to work really collaboratively with them. For others, they kind of say, you know what, I can let you manage this and I will take them back when they have strep throat. So long story short, we can work very collaboratively, and really it depends on the referring provider's preference.
Thanks, Jen. And Erin, you talked a bit about telehealth burnout, Zoom burnout. This attendee wants to know, how do we handle missed appointments or lack of engagement with teens?
Yes. I like that you mentioned with teens. It happens with parents as well. I think, sometimes teens get the short end of the stick that, well, teens don't want to come to family therapy, but who else doesn't really want to come to family therapy? A lot of parents, right? And so I get it. I'm sometimes tempted to miss appointments with a dentist or a pediatrician, and this is even harder work. So one of the great things about Equip is the technology. So if somebody misses a session, we can message them right away. We can do 15-minute sessions. We can do 30-minute sessions. We can do hour-long sessions. We have a lot of flexibility. So let me give you some examples of how we've used it. One is we really work hard to talk about all the different ways that they can use messaging and sessions. And then that gets reinforced by the 5 or 6 Equip providers that they have. The next thing we do is kind of a foot in the door technique, right? So saying, oh, my spouse is never able to attend family therapy sessions. Let's have a 15-minute session at 7 p.m. They can do that, right? Like anyone can do 15 minutes at 7 p.m. It gives us a foot in the door to start making a relationship. And so sometimes when, patients are probably the slowest to engage, they can take up to kind of even 2 weeks to really engage with their peer mentor, and then they really hit their stride. So there's lots of different techniques we use both over text and over video, and using different durations of sessions and at different times to help reach out to them. But that being said, you're right. We will not keep a patient if they're not utilizing Equip. That being said, we have over 96% of our patients stay with us, are retained month over month, and are engaging about 4 to 6 sessions per week and about 35 messages exchanged per week. So they're very actively engaged, even if they don't want to be at first. But this kind of leads into the other most common question that we get from providers. It's like, well, what if FBT doesn't work for them? And for those of you on this call, I'm sure you've seen families who you're like, they would not be a fit for FBT, or they've done FBT and it hasn't worked. So I kind of have a 2-part answer to it. First, what we're doing can't be called FBT. In the manual, it's just once a week with a therapist. And while Daniel LaGrange who's the father, a co-father of family-based treatment, he'll be the first to say, like, FBT is our foundation, but FBT isn't what we're doing. We're giving a 5 or 6 person treatment team who are all trained together in FBT, but are figuring out practical ways we're a little bit more directive. We give more advice than in traditional FBT. So we have had a lot of families who've done FBT before and it wasn't a fit for them. One in particular that I like to think of, who'd gained 0 pounds in 5 years. And so it was just the parents were just trying to tread water. Let's just make sure that they don't lose weight anymore. And then in the first 4 weeks with Equip, they gained 10 pounds. And so I actually called this family and I'm like, I want to know why. Like, you've had excellent FBT therapists, you went to an excellent IOP. Why do you think this worked for you? And they said that they had just tremendous treatment fatigue. Like so many other kids, their child was hypermetabolic. So they had to eat like 4,000 calories per day. And it really helped having this 5 or 6 person treatment team who was checking. There's always someone at Equip checking in with them, either via a session or a message, or sending a learning from our skills library, reminding them what they needed to do and how to do it, really help them combat the treatment fatigue. That being said, there are going to be families where FBT is just not the best fit. So every 4 weeks, we stop and pause and we look at the data. If they're on weight restoration, are they gaining at least 1 pound a week? If they're not on weight restoration, are their binge symptoms decreasing? Are their purge symptoms decreasing? Is their secretive exercise decreasing? Is the frequency with which they're self-harming themselves decreasing? We look at all those things every 4 weeks and say, is it staying the same? Are they treading water or are they getting better? And if they're treading water, then we have to change something. And one of the things that we're willing to change is to pivot from FBT or from a family-based treatment plus model to individual treatment with support for the family. Because if your child's still living at home, you still need to be engaged in something, but it doesn't look anything like FBT at that point. I will say though, we're really bad at predicting who's going to be a fit and who's not. Most of our families tell us, I think I'm going to be one of the families that at week 4 pivot to individual. Most families aren't. Most families end up continuing to be very, very involved in treatment. So as you're thinking about different people who maybe could benefit from Equip, I really encourage you not to kind of screen people out. It's really our job to help people do the thing that they don't want to do, just be involved in treatment.
Thanks,
I also
Erin.
just wanted to add a quick note on chosen family, because we really do utilize the term chosen family. And it's really our job when you come into treatment to work with families and say, okay, who is going to be your support person? And just a little preview, as we are working as fast as we can to turn on the adult population, it's a similar model, right? As Erin talked about before, we know that eating disorders are brain disorders. And I like to say, it's not that folks are choosing not to eat and engage in pro-health behaviors, it's that their brains aren't letting them. And for an illness where you need to fight your brain 6+ times a day, every day, you really need folks around you to help structure that and help make it a little easier on you. So that will be the role as we move into adults as well.
Thanks, Christina. And similar to what Erin was touching on, we've had some conversations with providers recently where they wonder, can a family who the family members might have had a history or currently struggle with disordered eating be a fit for Equip? So JD, I'd love to hear your position on how our providers address disordered eating behaviors in the patient's family members.
Yeah, I first want to echo what Erin said. On paper, our family would not be successful with FBT for a variety of reasons, including that my husband was living elsewhere for work at the time. So I'm really a big fan of giving people the information about what it is and then letting them decide what they can and cannot do. And in terms of disordered eating and even eating disorders, one of the additions of family mentorship that is so powerful, our clinical folks have limitations sort of sometimes on how raw they can be. And how direct they can be. And we find that the relationships we have, both individually and within groups related to disordered eating, dieting behavior, a lot of range of socially normed things that do not support eating disorder recovery, we can have those conversations very directly, and we are based in non-judgment and non-shame. People are engaged in societally normed behaviors. Sometimes they're engaged in medically advised behaviors. And so when we approach this with non-judgment, non-shame, and curiosity about how we best build a recovery supporting environment, it's the most amazing thing when not only does the child recover, but a parent also begins to heal from either disordered eating or an eating disorder. And I will always plant my flag for, we all have heard of the stories of parents who have picked a car up off a child. This is an equivalent process. And as parents, we love our kids and we can do that.
Thanks, JD. We haven't talked much about ARFID, which does make up a significant portion of our patient population. Jen, I'd love for you to touch on, our resources and provider specialties for treating ARFID, how we measure success.
Sure. We have all of our providers are trained in avoidant restrictive food intake disorder treatment. We do have some peer and family mentors who have that particular lived experience, and we try to match them up with patients and families when they're admitted into our care. And we also have specialty questionnaires that we use in this patient population. We recognize that the treatment approach can be quite different and really adapt the family-based treatment in interventions in that way. And we also know that a lot of our individuals that we work with our FID have co-occurring anxiety disorders. And so those are the patients in which I and my colleagues on the psychiatry team are often quite active in really trying to treat those co-occurring conditions.
Thanks, Jen. We have time for a few more questions. This one just came in. Megan, I'd love for you to share what is Equip's philosophy in terms of how a patient's physical activity is viewed and handled?
Sure. So I think that's something I'm very, very passionate about. We share the family and the patient's enthusiasm about getting them back to their sport, if indeed that is what they want to do. So when someone comes in initially, we ask that they're pausing their activity just while we evaluate them for safety. So they have to first be medically cleared and then also kind of cleared by the team to ensure that we're safe to move them forward. But as soon as it's safe to do so, we do like to help someone get back to activity. And one of the reasons is that there are tremendous therapeutic benefits of engaging in physical activity, and many of which kind of help with the co-occurring issues that our patients are struggling with. So I see a great value in that. And also it's kind of part of them building that life worth living outside of the eating disorder and outside of treatment. It may be in part that they were engaging in exercise because of the kind of compulsive or compensatory aspect. It's regarded as a behavior in that way, but there are also other motivations as well. It's enjoyable. It helps them socialize. Their peers are also engaging in the sport. So we're able to kind of move them back to that as quickly and as safely as possible while kind of exploring their motivations for engaging in the activity. We're helping the parents and the patient understand what it takes to refuel. I usually say if you want to be an athlete, you have to be willing and able to eat like an athlete or feed like an athlete. And that's also true for the folks that are kind of more casually active and not engaged in like a sport specifically. And the research is kind of catching up with this as well. We know that it's safe to return patients to activity at an earlier point than we were doing in previous years and decades. So that's been really fun to see that come to life here at Equip. And I think our patients and families really appreciate the guidance as well. And I think it's important that it happens while they have the support around them versus kind of discharging in maybe more traditional settings, discharging to home and maybe not having a team around to help manage the urges and help with the refueling and kind of to give sports nutrition guidance to the families. It's been really fun.
Thanks, Megan. And Erin, I have a question for you. This is a very frequently asked question. What level of care is Equip?
That is such an excellent question. Equip is for everyone with an eating disorder who is medically stable. I think oftentimes, and all of you who've treated eating disorders recognize this, there's not really a lot of mild eating disorders, especially because eating disorders tend to not get diagnosed until 3 years after someone's already been sick. So we see some of our patients where we're the very first treatment they've ever had. So they've just been diagnosed by their pediatrician and sent to us. And we are, so in many ways, it's like a traditional outpatient setting. We also have a lot of patients, about a third of them, that come straight to us from an inpatient hospital stay where they were medically unstable and discharged straight to Equip. So we're able to take all acuity levels. And one of the things that a lot of pediatricians and families like about us is that they don't have to change treatment teams. So we have partnered with our payers to offer treatment as long as it's needed. And so that means, and with the unlimited sessions, we can titrate up or down or increase or decrease the number of sessions depending upon how the patient's doing, what the patient's needs are, how the symptoms are doing. So we're able to stay with them throughout the duration of both their illness and as they go into recovery, but also do relapse prevention.
Thanks, Erin. Okay, these are our final two questions. If we didn't have a chance to answer your question, we will follow up by email. But Erin, I'll have you take this one as well. How does our FBT approach translate to treating binge eating disorder? Do we alter our approach, or is it shown to be as effective?
Yeah, we definitely do alter our approach. And family still needs to be involved. So oftentimes with both bulimia and binge eating disorder, the person who is working on their recovery gets to take over a bit more control than if they had anorexia, for instance. And we want the family to be able to learn what are the things that they're doing that are really helpful, but also what are the things that they're doing that aren't helpful? While families aren't to blame for eating disorders, they can accidentally do things that really reinforce the eating disorder or make it hard to recover. So this can be family doing things that are fat phobic. This can be family not having the right foods in the house or the right type of structure. So we want both the person who is struggling with, in this case, binge eating disorder, and their family to help structure the home for pro-health behaviors. So we incorporate them, but you're right, it looks a lot different. We're not having the family necessarily plate the foods. I will say one thing though, a lot of people who struggle with binge eating disorder restrict in a way that's incredibly similar to people with anorexia. So we see a lot of people who don't eat for 12 hours before they have a binge episode. And a big part of recovery is stopping this restriction. And that's when it's really helpful to bring in the healthy adults in your life, be that chosen family or biological family, and have them help you to stop that restricting cycle that comes before the binge. So maybe that's eating breakfast with you. Maybe that is helping you plate breakfast. It's going to look a little bit different for everyone, but we still need our family to help us recover.
Thanks, Erin. And I'm going to pass this last question to both JD and Maris, because there's been so much excitement around the mentorship aspect of our program, and we have a lot of prospective families on this call. What would be each of your one tip advice for taking that first step toward recovery?
Before I answer that question, I want to say they've been seeing a lot of questions about sort of what is recovered, what do we consider recovered? And I want to say from the family perspective, and I think this is why it's so important that we have the family perspective, families are the best people to identify, families and the patient themselves, when they're in recovery and when they're recovered. So I will always say to families, it's when your child is back. That's when we would call them recovered. We're looking to families to give us that answer. And so I would see that, the most important thing is to begin where you are. Don't look backwards. You can't move forward when you're looking backwards. And so we meet families where they are, and we'd love you to meet us where we are. And then together we'll move forward.
Thanks, JD. And what about you, Maris?
Katie, you stole mine because I think it's a really good one, that there isn't a perfect time to start recovery. And if you wait for a perfect time, you'll end up waiting for a really, really long time. So exactly what JD said, now can be the perfect moment. So we're definitely here to support you where you're at.
Thanks, Maris. And now I'd like to hand it back to our CEO, Christina Saffron, for just some closing remarks. And thank you all for being here.
Thank you all so much for being here and joining us in this journey and this mission to ensure that every single person with an eating disorder has access to treatment that works. It always strikes me that eating disorders have the second highest mortality rate of all mental illnesses. And yet when folks have access to treatment that works, they go on to channel those temperament traits that make them vulnerable to an eating disorder into some amazing, creative, incredible ways, and go on to do amazing things. So thank you guys for helping us to make sure that recovery is possible for everybody and inevitable for everybody, as we like to say here at Equip. We're really looking forward to staying in touch. You can email us, you can visit our website. Please get in touch with us, and we'd be really thrilled to help the families that you work with.